presentation mode and platform. You are welcome again for today, and we want to say that yesterday was very fruitful. We also expect today to be fruitful. So we have this session which is about to start. It will be free until 10:30 for all the professionals. And then after that, we will lock it for those who registered for the conference. And the current chair, who is supposed to lead the session, is from Tanzania, and we are trying to reach her. Meanwhile, I will step in for the chair before she joins our meeting. Maybe it's because of some hitches. And as we said, maybe Anthony, you can share the program with me. Just bring the copy that you have. She's in. So I'm told that the chair of the session is in, and I would want to welcome her officially so that we can start. We had already prayed, and so let's have Dr. Domina Esther from the Republic of Tanzania to take over the chair and begin the process. I hope you already have the program. This morning we are supposed to have one presentation from Brian physically here, and then we get to the side event from Dr. Keo and then Joan. That is free, Dr. Domina. Then after that, we'll have it locked. So please, you are welcome. You can introduce yourself and then you take over.
Thank you very much. Good morning, everyone. For those who are joining around the world, a very good afternoon and good evening, and a very warm welcome to everyone attending this session. My name is Dr. Esther Nkuba. I hold the position of Director of Nutrition, Education and Training at the Tanzania Food and Nutrition Center. It's my pleasure to serve as your chairperson for this exciting session. We will have a 15 minutes presentation from Brian, and it will be followed by mainly 5 minutes question from the audience. Thank you very much. Mr. Brian is going to present on the VAS Plus Pro, an Android scalable web application, 100% coverage and data quality monitoring of vitamin A deworming and childhood immunization. This work will perfect is under our sub-theme of applied IT support for nutrition and dietetics intervention, addressing the vital challenges of monitoring and ensuring this life-saving intervention. Please join me in welcoming Brian. Brian, the floor is yours, please. Can you upload the presentation, please? Hello.
So, good morning, everybody. My name is Brian Marcia. I'm a nutritionist working at Kwale County Government, stationed at Kinango Sub-County Hospital. So, my presentation is about VAS Plus Pro program, which is an Android scalable web application for 100% coverage and data quality monitoring of vitamin A deworming and childhood immunization. It is under the theme of the role of nutrition and dietetics in health system strengthening. So VAS Plus Pro is a computer-based program for strengthening primary healthcare systems through active registration and monitoring of children below 5 years. The initials VAS stand for vitamin A supplementation, while plus is intended to point that there are additional services, that's deworming and immunization. Pro in the initials stands for program. So this program offers a one-time registration of children and their schedules of vitamin A, deworming measles, rubella, rubella 1 and 2. That is MR1, MR2. The program works to flag out all due soon children and provides an on-the-go comprehensive client list of services, defaulter lists, with clear biodata, details, and services for which the client is due. So the objective is to create a computer-based monitoring and surveillance tool to provide an effective, efficient, and sustainable method of scaling up of childhood vitamin A supplementation, deworming, and immunization services through real-time monitoring of due soon and defaulter clients that guarantees 100% of achievement of coverage targets while safeguarding data quality. So to validate performance, multiple damaged child health records, I'll use this one, reflecting national schedules for vitamin A supplementation and deworming, and MR1 and MR2 were entered to test functionality, coverage calculations, and alert accuracy. Across repeated test runs, the application correctly identified every child approaching services due dates and accurately flagged or simulated defaulters, specifying the services missed. It produced downloadable defaulter list in PDF, Word, and comma-separated value CSV formats, greatly reducing the time required for manual register checks. The interface proved intuitive, and the reports were well aligned with routine monitoring needs. There was no overachievement recorded during the SS because the performance could not exceed 100%. I will go now demonstrate on how the program works. So as I said, it's a computer-based program hosted on the web. So what happens when you log into the program or when you open the program, the homepage displays the following. The logo is a tab for a tablet to mean or to depict deworming tablets or the vitamin A capsules. And then there is a syringe on the logo that depicts immunizations in terms of measles, rubella, and all other immunization schedules under the KP, AMA AP. So it's under the mantra of Beyond the MCH trademark. Looking at the homepage, not homepage, but pre-logging page, you have the notices tab. The notices tab is used to display updates. For example, when you look at the current notices page, you'll see that it's showing that there's a KNDI 5th International Nutrition and Dietetics Scientific Conference that's ongoing. That's a notice. And then you look at another notice that says that there's an upcoming event from Kwale County for a conference for nutritionists and dietetics on 28th of November, 2025. There's then the login page where registered users are allowed to log in. There's a register tab where users are allowed to apply for registration as a user. I want to point out something. When you are registering as a user, there are certain roles that are allowed. The role that you are registering as determines the level of access to the program. So you have the national, county, sub-county, facility, CHP, and guest users. Those are different levels of users, and whatever level of a user you are will determine the level of access that you have to the program. So I go straight and demonstrate with a login. I have, as I said, you have dummy data that was used to test this program. I'll register with a facility user rights. So when you log in to the post-login page, you'll see there's a dashboard and all those menus. The dashboard basically tells the user, depending on level of access, will be able to display the summaries, how many users are active, the total number of clients for that user. If I'm a facility user, let's say for facility X, and I have 100 clients or 100 children coming for CWC follow-up, we'll be able to display how many clients. To also be able to show you, I'm logged out. So it will also be able to show you the defaulters, if it's a defaulter for technology caps. So you can see we have defaulters. It will be able to tell you how many defaulters have defaulted for vitamin A 12 to 59 months, how many defaulters in your facility defaulted for vitamin A 12 to 6 to 11 months, how many defaulted for MR1, and how many defaulted for MR2. And then after the summary dashboards, you'll be able to see the charts for your facility to show you the performance and performance gaps and performance achievements. So you can see for this facility, Samburu Sub-County Hospital, you'll be able to see for vitamin A 1259, how many, what's your coverage, is it 100%, what is the gap? But then straight to the point, as we said, that it flags out defaulters. If I want to know, like I'm having, as per the program, 3 defaulters for MR1. If I want to see where the defaulters, where do they come from, I'll go to the reports tab. And under the reports tab, I can either send a mail or whatever, but I'll look at the defaulters to draw the defaulters list. So this program will be able to list for you the defaulters, the name of the defaulter. For example, number 1 is Joyce Munga, with the caregiver, the age of the defaulter, and the facility, the county, the sub-county, and the village from where they come from. And then it will be able to flag out which services has this patient or client defaulted for. The first client has defaulted for MR1 and MR2. So what do I do as a healthcare provider? I just use the guardian's contact list and make a phone call to the guardian. Please bring so and so. They are due for this service. I can as well look at that data and see which villages perhaps are the most affected with the defaulter issues. And then, for example, you can see Samburu T and Samburu T villages have high defaulter rates. You can target interventions, perhaps outreaches, or reach out to the healthcare promoters that area and find out what could be the reason why we're having high defaulter rates from that village. You can organize mobile outreaches to reach to those areas. Again, as you can look at the defaulter format, I mean the defaulter platform, you can download your list either as a CSV, comma separated values, or perhaps Excel, or you can download as a PDF, you can download as a defaulter if you want to email to somebody or for management purposes. You can as well print your list for filing purposes. You click on print, it will send you to the printing platform, and you'll be able to select the printer and print your client list. So essentially, this is a major role of the VAS Plus Pro, and it's just to flag out due soon, to tell you these are patients who are due for this service. If it's MR1, it's MR2, it's vitamin A for 12 to 59, or 6 to 11, or it's deworming, whichever service they are due for, or whichever they have defaulted for. So basically, that is the VAS Plus Pro. I will not really get into other details of the program, but I also want to point out that users must be approved. You have a user management tab, which helps you to manage a user. If a user tries to apply to become a user, like a facility user, sub-county user, it awaits approval from a higher level user. If I'm a facility user, I cannot log in unless my user account has been approved by a sub-county user. The sub-county user must be approved by a county user, and the county user must be approved by a national user. In terms of client addition, you click on the add client depending on your level. Only a CHP level and a facility user are able to add clients. Sub-county levels and above can only view charts and dashboards, but cannot add or edit clients onto the program. So if a client comes, you'll be able to fill their biodata, mimicking the CWC and immunization registers. And once you enter the data, it will automatically pick. If I'm a facility user registered for Samburu Hospital, I cannot register for another facility, and I cannot access another facility. And then when you want to view your clients who you've already registered, you click on View Clients tab. You'll be able to see the registered clients, and it will give you a summary of the clients who are already registered. If you want to search for a client or to filter, you can come to under Client tab and perhaps specify a specific client. It will give you data for that client, including what services they have received and what they are due for and when, including their age, where they come from, and all that. So under the user management, every user has their right. Some users have a right to delete, to suspend, or to activate or reactivate a client. So basically, this is in a nutshell the VAS Plus Pro. And I yield my time for any questioning and inputs or clarity. We can't really discuss this in 15 minutes or 10 minutes, but I wanted it to display what it does to generate the defaulter lists for you as a healthcare provider to be able to get them without having to peruse thousands and thousands of pages in your user registers. Thank you very much.
Okay. Thank you, Mattia, for your good presentation. This time is time for for questions. He has presented you well. Congratulations. And this time is for questions from the floor or any additional points, please. You are welcome.
Thank you, Brian. I'll ask you the first question. Now, this tool, is it only for your county, or is it a national tool?
Okay, if perhaps the city can display, when you are registering as a user, I have made it scalable actually globally. You can see you'll be able to select the country from where you come from where you're registering. For now, I've put about the East African countries, but I've also put another aspect of other. When you see you come from other country, then another field opens up for you to say which country. So again, so it's scalable globally. And other than the national user level, there's the overall program administrator who is able now to open for each country their own program account, and then they run their thing. And there's user role designations. A county X cannot view data for a county. Why? So a country user X cannot view data for a country user. They purely manage their data.
So this is your innovation.
It's my innovation.
And are people purchasing it, and who is in charge of the back end?
So people haven't purchased it because, first of all, I've not sold it to the market. I want to sell it to the Ministry of Health. It's more because it has to go for policy issues. First of all, I'm working to work with the county government of Kwale, my county where I work in. Once it's approved for running, because I already presented the facility level, and they are ready and willing to buy the idea. Perhaps from January, be launching it, operationalizing it as a QIT program, quality improvement team program. So I haven't yet sold it out. And number two, running the back end, I am the program administrator currently. So any updates, any changes, and suggestions, I just code them by myself. Thank you.
Yeah, I don't know.
You said once you register for under facility X, you can't register for facility Y. So what happens if I move from one facility to another?
Yeah, very good. What happens is, if there's a transfer from one facility to the other, under user management tab, I have allowed a user to only edit their name, their contact details, and their email. You cannot edit your facility. So if you go to facility X, you are going to just edit the details from this facilities. Let's say I'm in facility X and I'm moving to another one. I just go and edit the details for email and for the phone number and for my names, but the data for facility remains. So it takes care of that, such that you cannot move with another person's data. Hope I've answered you well. Let me, if Fisher could demonstrate from the program, if ICT can display me. ICT, can you display my program, please, my computer?
As the program is being displayed also, just give us a hint of the security measures you have for data protection.
Yeah, so for data protection, number one, before, as I said, because of policy issues, I want to work with my county first to roll it out. So number one, before you register in clients, you have to get consent from the clients. And the other issue about data security is that there's password protection for every account, and you manage your own account with your own password protection. A user cannot register twice under the same account. And then there are logs, there are places for logs to show who did what. So the logs are able to show in terms of security parameters, who is accessing what, who has registered what under the logs section. So those are some of the security issues that I've been able to implement, but I'll be open perhaps to better it up. So just to answer you as I wait for the display from the ICT, if user Brian is working in Bagathi Hospital and is transferred to KNH, number one, the superior user can suspend user Brian, but now data will be lost for that facility because the data is not for you. You are just there as in charge for that facility, and that's why you're a user for that facility. So when you get transferred, there's a new user who comes. That new user, you give them the credentials that you are working on. But remember, you registered using your phone number and you registered using your email and your names. So the user who you've given rights now will just go under user management, if ICT could show, and just edit the names, put their names, edit the email, put their email, and edit the phone number, put their phone number. But the county cannot be edited. The facility cannot be edited. So you just edit those three elements to transfer ownership of the program from user X to user Y to maintain continuity of the data.
Thank you. We may not display your computer because it was a third computer.
It's okay.
So it has been disconnected.
It's
So I
fine.
think, Chair, the time for Brian has elapsed. So you can take back. Maybe we are going to proceed with the presentations from the sessions that were supposed to be starting at 11, as we wait for the side event and the keynote. So, Chair, you can take over and we move on with from Nyamizi onwards.
Okay, can you share me the current agenda for today? Okay, thank you for a good presentation, Mr. Brian. Your presentation highlighted on the critical gap, which actually we need. I would like now to invite the second presenter, Nyamizi. Is it Nyamizi, not Brian again?
So the next.
I have the audio.
Chair, I've said you start from 11. The timing, the schedule for 11 to 15, but we are starting with number 45.
We are starting number 45 with which is Brian Bakari. Buran.
Yes, Buhan Bakari. Yes.
Oh, okay, thank you very much. Now at this time, I would like to invite Bakari Buran, if he is present, to take over. I have different timetable here. Sorry for that.
Thank you, Chair. We will update you on the sequence through Zoom. So just keep on checking.
So thank
Brian,
you very much.
are you
Yeah,
present?
I'm here. Yeah. So from Brian to Burhan. My name is Burhan Bakari, and I'm the sub-county nutritionist in Samburu sub-county. And the topic of that I'm presenting is addressing iron deficiency anemia in maternal health which focuses on the effects of psychosocial support groups in Samburu sub-county. We all know the risk first factor. Yeah, thank you. We all know anemia is a risk factor for in pregnancy, and also has adverse outcomes in pregnancy, including maternal death, low birth weight, stillbirths, among others. And the burden is also high, both globally and nationally. And it's associated with various outcomes, such as fatigue, other psychosocial issues, such as mental disorders, and actually, among the comprehensive management in anemia. Next slide. So the psychosocial support groups is part of the holistic management of the iron deficiency anemia. And the project actually came about after we had high cases of maternal death. And during the MPDSR meetings, we agreed that we needed to come up with an intervention that will actually address the issues of maternal deaths. So among the interventions, we agreed that we at least give the mothers a common TCA so that we can have a group and at least manage them in group approach. So initially, we formed the group, and then after 3 months, we realized that there was a positive outcome. So to look at the effects now of the group approach, we decided that we needed at least another group, at least to show the comparison, where we have the group approach and where we don't have the group approach. So Samburu Sub-County Hospital became the intervention group, whereby we had 2 groups initially of 20 mothers, or 40 mothers, and 2 groups that will be 2020. And then we looked for another high volume facility. And Samburu Sub-County is a new established sub-county. We don't have a health center, we only have dispensaries. So we looked at the high volume facility, which was Taru dispensary and which acted as the control group. So the interventions that we were in that the intervention group included demonstrations, how to prepare the iron-rich foods, knowing the food groups that are rich in iron. Also, we also invited other experts from other fields, such as agriculture, also finance, so that at least we could at least empower the women in form of knowledge and also in terms of income generation. Another slide. So the objectives, one, it was to evaluate the impact of the sexual support groups on improving maternal nutrition. Also, I think the changes in knowledge, also to integrate nutrition with other services, and also ensuring pregnant mothers have access to accurate information about anemia and management. Another slide. And then also to empower the mothers with practical skills related to meal preparation, cooking techniques, as I said earlier, and then foster a sense of community engagement, mutual support among mothers, and finally ensuring recommendations are realistic and feasible by tailoring nutrition advice to the community cultural context and respecting local traditions and preferences. Next slide, please. So the methodology, as I have said earlier, we had 2 groups. Samburu Sub-County became the intervention, and then which had 408 mothers. And then Taru dispensary became the control group, but the groups were unmatched. Samburu 408 and Taru dispensary were 321. The results, So after period 1 year, there was a remarkable difference in terms of the improvement in HB status. In Samburu, we had the mothers going up to 7.5 gram per deciliter. And in Charu, they went up to 4.5. Additionally, in Samburu sub-county, 6.6 mothers reduced between 0.1 to 1.5 after they had other underlying conditions, and 50% maintained. There was also a remarkable or a noticeable difference or in terms of outcomes, whereby in terms of birth weights and other outcomes in Samburu sub-county were actually good compared to Taru dispensary. Next slide. So the group approach actually enabled peer-to-peer learning and also encourage adherence to IFAS and also improved social well-being. Actually, the group approach doesn't necessarily cure the condition, but it improves the well-being of the mothers and also their quality of life. The integration of education led to improved knowledge in Irish foods. That was actually noticeable from the demonstrations and also how they took the intervention. And also the collaboration, the intersectoral collaboration with other ministries such as agriculture and others actually had a positive impact in terms of diversity, in terms of in form of setting up kitchen gardens whereby the mothers could actually replicate what they learned and what they practice in their households. Next slide. So results, as you can see, in Samburu sub-county, those that had low HB, which were 27, and these actually reduced, but those that had normal birth weight were 19, and 8 had low birth weight, and those that maintained were 61, and 90.2% had normal birth weight. For those that improved in HB, 95% had normal birth weight, while 5% had low birth weight. Next slide.
You have 3 minutes to time.
Thank you. Taru dispensary, for those that reduced, 82% had normal birth weight, and those that maintained had 97.7 normal birth weight, while those that improved, 70.8% had normal birth weight compared to 20% that had low birth weight. Next slide. In terms of comparison, we actually see that there is better outcomes in Samburu sub-county, which had the intervention compared to Taru dispensary. Next slide. Next slide. Next slide. In terms of preterm and term babies, the outcome were actually better in Samburu sub-county compared to Taru dispensary. Next slide. So the lessons that we learned is that the group approach actually help mothers to manage the condition well, and it has better outcomes, and it has been proven to be effective strategy to improve maternal nutrition, infant outcomes, and reduce the burden of iron deficiency anemia, as seen in this project. And also the intervention also enabled mothers to improve their quality of health and and services through embrace skill delivery and also uptake of IFAS. Next slide. So as part of the recommendations, at least the approach could be applied in other settings. It could prove to be a good intervention. And in conclusion, if the condition is adopted actually in similar settings, it can be a good strategy to achieve the SDGs as well as improving maternal health and outcomes. Thank you.
Thank you very much for your presentation, please. It's time now for question and answer, 5 minutes. You're welcome.
Chair, we have one here. And do you have in the congregation, among the participants? If you have a question, you raise your hand. Let me be the first to ask you.
Yes, doctor.
First of all, not only to ask, just to give you a tip. Anytime you present, just get to know that you are the owner of the knowledge.
Yeah.
And so you have to be confident. Are you hearing me? So that everybody can feel your presence with what you're communicating. It's one way to advocate for your matters. And also, when you make presentation, you conclude your presentation before you recommend. So that I've seen that even with a number of presentations yesterday. You conclude what you said to do, then you make recommendations.
Thank you, doctor.
On what you want. Otherwise, the presentation is good. Any comment? From online, just check if there's any question. If not, then
Anyone online, please?
Yeah, thank you very much. Maybe just to follow up in the group approach. I don't know whether you had the demographics of the group approach. Were there any influence of demographic characteristics, maybe education level, marital status, that could have influenced also the uptake of what you are studying?
Thank you, Prof. We factored in these factors, and okay, it was just a beginning of the intervention. We really didn't focus much on that. We focused on the intervention, but the project is still ongoing. Yeah, we're still going to incorporate that.
Okay. Do you have another
There is no comment
question?
online.
No comment, no question?
question. I think we can move to
We
the
still
next.
have 3 minutes. We still have 3 minutes to time. Okay, if there is no one, Doctor,
Yes,
can you help me the next
Chair,
presenter, please?
Well, thank you.
Chair, the next presenter is here physically, so.
Yeah.
Laura?
Oh,
Thank
and
you,
who
Chair.
is he?
So the next presentation will be Lilian Mutanu Umina. She's going to present on harnessing gut health to prevent obesity, a nutrition-centered approach for optimizing gut functionality in preclinical obese adults. Welcome, Umina.
Good morning. So my name is Lilian Momena. I'm a registered clinical nutritionist, and I have personal interest when it comes to weight management and obesity. And together with my counterparts, James Otieno and Grace Njogona, we decided to do this topic on harnessing gut health optimization to prevent obesity. That is basically a nutrition-centered approach for optimizing gut functionality in preclinical obese patients. So next slide. So before we go to the background, maybe I can give you a small history. We have seen a lot of rise in use of this pharmacological use of medication. It is a current trend in Kenya where we're having people self-medicating and we're having everyone out there prescribing them. And in the name of, or in the quest of chasing a slimmer or a thinner waist. And this is basically due to the trends that we have observed where we have global obesity rates actually increasing and tripling since 1975 to the current century. And we all know as nutritionists that the gut microbiota plays a critical role in nutrient metabolization, hormonal regulation, and energy balance. And this biosis that is basically altered gut microbiota contributes to inflammation, impaired satiety, signaling, and metabolic disorder. And early nutrition-based intervention targeting gut health may prevent the progression from preclinical to clinical obesity in humans. So this is basically a rough statistics of the obesity situation in regionally in Africa and in Kenya, as we have seen recently. The Ministry of Health, through the Cabinet Secretary, recently gave a notice on the increasing prevalence of childhood obesity. And there was also a research that was done recently that showed that more than 43% of urban women in Kenya are currently overweight and obese. And this highlights the importance of actually now looking for simpler it's not simpler, but cheaper or better preventive mechanisms when it comes to managing obesity. This is basically a image or a representation of the global obesity prevalence on how we have actually come from, even from us as a country. The other day we were being asked if we have the time to actually take care of our health, and most of us would actually say no. They will give a lot of excuses. And as we know, if you're not physically active, you're eating badly, you're not taking care of your gut, you're definitely going to gain a lot of weight. Next slide. So these were the objectives that we came up with, the main one being to examine the effectiveness of gut health gut health approaches as a cheaper alternative to preventive and management of both preclinical and clinical obesities. And the other objectives included to synthesize evidence from 2013 to 2025 on the relationship between gut functionality and weight regulation, to identify nutrition-centered strategies that restore gut functionality and support weight management, and to propose a practical dietitian-led protocol for preclinical obesity in Kenya. We don't have one currently. The next one. So the design that we used was narrative literature review, because we were basically using database from PubMed, Cochrane Library, and Scopus, and any other relevant data that we will come across. And some of our keywords will be gut microbiota, short-chain fatty acids, dysbiosis, obesity, prebiotics, probiotics, and nutrition intervention. And the inclusion criteria was on human studies, meta-analysis, and mechanistic studies that link gut composition to metabolic functions and weight outcomes. So the key findings were reduced microbial diversity and altered firmicutes or bacteriocytes. That is basically the good and the bad bacteria ratios actually are very prominent in preclinical or obese patients, and dysbiosis correlates with inflammation, impaired short-chain fatty acid production, and decreased basal metabolic rate, leading to the increased weight. And of course, gut-deprived peptides, that is the GLP, and microbial metabolites regulate appetite and satiety through the gut-brain axis, and nutrition interventions, such as increased dietary fiber of roughly between 25 to 38 milligrams a day, fermented foods and polyphenol-rich plants, improve microbiota, diversity, short-chain fatty acid synthesis, and metabolic outcomes. So this is just a rough estimate of how we are doing as a country. Of course, in Kenya, more women are more obese than men, and this is just a projection from 2014 to 2022, according to the Kenya Demographic Health Survey. But of course, the numbers might be higher because we are known to, I don't want to use the word cook, but we are known to actually just use data from our offices or our boardrooms to come up with statistics and then do a good presentation on them that do not actually depict the real picture of the situation on the ground. The next slide. So why is this relevant, or how can it be relevant to the policy? Because when we focus on nutrition support, it can actually aid and help in obesity prevention that is drastically rising in Kenya. Of course, if you compare with other developed nations like the Western nations, the Europe, the USA, the American and such, of course, the numbers might look significantly lower and they might look like they are not an emergency. But those, if you check on the trends from where we are coming from and how we are going and what we are doing, then this is the right time to actually make sure that we implement or we focus on championing for implementation of such inclusion of nutrition, gut-focused intervention in management and prevention of NCDs in Kenya. And of course, this also aligns with the National Nutrition Action Plan for NCD reduction. Next slide. So these are basically the proposed dietitian, where the clinical nutritionists now come in with the interventions, where they'll do a baseline. Of course, there's also in the intervention and what will be monitored. And of course, we have the anthropometrics being some of the indicators for the baseline. And for the intervention, we have gut health, stool quality, movement, and adherence support. And of course, we monitor on weight, satiety, and metabolic markers. Next slide. So this is a visual representation of the impact of dietary fiber on gut microbial diversity, where we have consumption of low fiber diet actually being associated with imbalances, like we have a small percentage of the beneficial bacteria and of course an increased number in the potentially harmful bacteria, and the neutral bacteria actually being lower. And then we have also with the high fiber diet, high consumption diet, that is basically the use of good foods, the good bacteria actually increase, and this has actually been shown to have a positive impact when it comes to metabolic regulations. Next slide. So these are the practical implications. I've just heard Dr. saying that we don't give recommendation before we conclude. So allow me to just do that. So we need to champion for improved financing in nutrition in Kenya and promote and support gut-oriented research for nutrition program. Next slide, because my minutes are running. So this is the conclusion and the way forward. We have to optimize gut functionality, as it has been shown to improve metabolic function, metabolic health, and prevent obesity in our population. And further Kenyan-based pilot studies are actually recommended because they are missing when it comes to gut health. And of course, we call for multidisciplinary collaboration that is basically between dietitian, clinician, physicians, and others, so that you can actually be able to prevent or to curtail the increase in numbers. These were our references. And yeah, the authors of this were myself, Lilian Mumina. We have Grace Nyawira Njogona, and we also have James Otieno. And of course, questions we are welcome.
Chair, back to you. Chair, you can come in.
Is okay, me?
Yes, Chair.
Hello.
The presentation.
Yes, you're
yes.
welcome. I welcome the floor for the question. For the questions and any discussion.
Any questions from?
We have 5 minutes, please.
Mine is not a question.
Chair,
it's just
actually, is 1 minute. It's not 5 minutes.
Okay.
Yes, she has
Thank you.
consumed all her time.
Thank you for
yes.
mine
Yes.
is not a question. It's just to commend you. That was extraordinary, and I think you have charted new frontiers of knowledge that have not been really exhausted as the world grapples with the challenge of obesity. Keep up.
Thank you. Thank you.
I have one question for you, Mumina. When you're dealing with matters of obesity, I don't know whether you also focus on the specific body composition, because obesity, maybe you may be able to tell us the standards that you're using. The body, I think you're probably basing it on BMI. And in your aspects of management, are there specific consideration around the specific body composition? Because sometimes somebody has predisposed more muscles and have heavier bones. In terms of your assessment, you'll be able to end up with what people call obesity. So if you don't actually take into consideration the actual body composition, then you may end up doing either a bad diagnosis or sometimes introducing intervention why it wasn't necessary. Do you take that consideration?
Yes, thank you, Prof, for that. In the nutrition-led suggestions that we did, of course, baseline assessment was one of them. And of course, because of the involvement in technology, we have, of course, body analyzers being used. And of course, we are championing for them to be adopted in the public and the private practice, where we can actually have better and improved assessment data when you're managing. Of course, that is definitely a consideration. Okay.
Thank you very much for your good presentation. I welcome the next presentation,
Chair,
as I don't have the.
Chair, we have a little bit of a change, so Mumina, you can take your seat. We have the keynote to come in now, because
Okay.
and it is your responsibility to introduce the keynote,
Unfortunately, I don't have
the program.
the program today.
Okay, so
Can you help on that, please?
we will do that.
Yes.
Yeah, Professor.
Thank you very much. We are going to go on our keynote today. Dr. Joan Bonilla. So, Dr. Joan Bonilla is going to give us a presentation on challenges in long-term adoption of biofortified foods, the case of Tanzania. Joan Bonilla is a managing economist at the American Institute of Research. He has over 15 years of experience conducting research projects in sub-Saharan Africa across agricultural development, nutrition, and social protection. Many of his evaluation include mixed methods, process evaluation to assess implementation, fidelity, and program scalability, as well as cost benefit and cost effectiveness analysis. Before having gone to AIR, which is American Institute of Research, he taught graduate courses in development economics, program evaluation, and empirical methods in microeconomics, the University of Sao Paulo in Brazil. Dr. Bonilla is a member of editorial board of the Journal of Research on Educational Effectiveness. He holds a PhD in economics from the University of Maryland and a master's in economics from the New York University. Allow me to welcome Dr. Bonilla to give us the presentation on the challenge in long-term adoption of biofortified foods, the case of Tanzania. Welcome, Bonilla.
Well, thank you very much. It's very nice to be here with all of you. I really wanted to thank the organizers for having us here. It's very important for us to be able to disseminate the work that we do. I have the chance to have a conversation with people who are working on these topics and knows so well what is happening in terms of nutrition in some of the sub-Saharan African countries and in Kenya in particular. So I really appreciate the attendance. I'm gonna start basically saying that I changed slightly the focus of the presentation for one reason. So what I'm gonna be doing today is basically presenting a couple of different projects that we have been evaluating in the area of nutrition. One of them is specifically related to the Tanzania one that you were referring to. But that project, which you will see a little bit later, it is also on the promotion and adoption of orange fleshed sweet potato. And in many ways, that project is very similar to some of the things that we were seeing on the keynote speaker provided given by Jan Low 2 days ago. So I thought that it would also be interesting to complement some of those things that I'm going to be discussing with work that we have also been doing in the area of nutrition, including some work in Kenya as well. So there's, as you are gonna see, it's kind of a mix of different things, and with the idea of presenting today some insights in terms of what it means to conduct these evaluations that are at the community level. So basically trying to determine what are the impacts of nutrition programs on final beneficiaries, which we have been discussing here in this conference. The importance also to going back to the potential beneficiaries and understanding adoption of the different things that are being promoted. So that's what I'm going to be presenting today. One thing that I want to say before I get started, the projects that I'm going to be presenting are is part of it is work in progress. So we really appreciate also the support that we get from the different organizations that have trusted us to be able to conduct those those evaluations. In particular, I'm thinking about the GAIN, the Global Alliance for Improved Nutrition and Care, as well as the AIR Opportunity Fund. So let me, next slide, please. And then the next one. So let me get started with kind of a big picture of when you evaluate programs in nutrition. What are you basically evaluating for the most part? There is so a lot of common aspects of many of these evaluations. And for the most part, many of these programs are designed to improve food security, reduce malnutrition among children and women of reproductive age. So it has that component of specific population targets, right? And you will see very often the women of reproductive age and the children being quite important in many of these programs. And usually when you evaluate this, many of the interventions have in common the fact that they want ultimately to improve the access and consumption of healthy diets, improve really nutrition in a very integral way. And through nutrition also to be able to make those households and those target populations more resilient to basically whenever there are shocks, in particular in many of our countries in sub-Saharan Africa, where there is still a really large part of the population who are still agricultural households producing their own food and being exposed to the different types of shocks, including shocks in weather conditions. Next slide. So in many of those evaluations, when you are evaluating these type of programs, you will see that there is always many different types of activities. So, and this is good. So many of those programs that are trying to tackle ultimately what happens in the household, you need to do many things in order to be able to change that behavior. You need to work with the government. You need to understand the regulations with the policies. You also need to understand what is the role of the private sector, right? For example, those organizations that are either providing services or involved in the fortification of some specific food items for the household. So, and and in addition to the government, to the national or the federal level of government and the private organizations, you also need to start working at the community level with the local authorities. And then finally, you also have components that is really working with people in the communities. If the project has a specific target on women, then basically understanding what are the type of things that they are missing. Are they missing? Do they need support to get knowledge about what is important for nutrition? Do you also need to provide some sort of inputs for them to be able to adopt, for example, new types of crops? Do you need to also support them and form women groups or VSLA groups in order for them to have enough resources in order to be able to adopt some of the things that are being recommended, and ultimately also increase the bargaining power within the household, so that women in the household are also more actively engaged in the decisions that are related to nutrition in the longer term for the household. So you have all these different components, and the evaluations need to take that into account. So it is very important to collect data at the household level, but you also need to understand all those other aspects that are happening with the national level regulations, with the private sector providers and the local authorities. And ultimately, if you do that, then you go to the long-term outcomes with the idea that you will be able to increase access to, as I was saying before, for example, improving diet diversities and the consumption of healthy diets, in this case, for one of the projects that we are evaluating, and resilience. Next slide. So let me tell you a little bit. I think you guys are also very experienced researchers, so what I'm going to be describing here is not uncommon, but I still think it is important to kind of go over some of these ideas. So whenever you are evaluating these very comprehensive interventions, as I was saying, you need to use very different types of approaches, research approaches, right? So on the one hand, using quantitative components, that we call it, that's household level surveys where you go to the household, you interview the potential beneficiaries, and you do a very detailed survey on all the different outcomes and mediators, and collecting data on the household characteristics, so that you really understand what is going on at the household level. So that's point number one. And then point number two, given that when collecting quantitative data is not enough, sometimes you just get the averages and you are missing a big part of the picture. Part of that picture is going to be filled by collecting also qualitative information, not only at the community level, but also qualitative information about all these other components that I was referring to. So being able to understand and interview qualitative, like conducting qualitative interviews to people at all the different levels of the government, both at the national level and the community level, but also understanding what is the role of the private sector, for example. So you, by basically combining all these different methods, you will be able to get a much better picture of not only if the program is allowing you to make some changes in the outcomes that you want to change and behavior that you want to change, but also the reasons behind it, the drivers, the mechanisms. Why are you able to observe the impacts? Is gonna be something that is going to be given to you thanks to a large extent to the qualitative work. In many of these evaluations, we tend to collect data at multiple moments in time. So for example, what I was saying here is you collect, for example, data for a baseline and an endline. Some of the examples of evaluation questions that you would see, for instance, is what is the impact of a given program on diet diversity for the women of reproductive age, or to what extent the program improves the nutritional resilience, to what extent the program is also increasing knowledge and skills to produce those nutritious foods, and also to what extent women have increased knowledge and skills to adopt healthy diets, right? Those are examples of potential research questions that are more at the impact level. But also, as I was saying before, with the qualitative data, you may be able to understand things related to the implementation of the project, right? So for questions, for example, like what is the how the program is able to implement um, and change um, uh, the outcomes of interest thanks to the policies that are being implemented, or what are basically the linkages between the private sector and the public sector in order to be able to create those outcomes, and ultimately also to understand all the implementation projects have an original plan, but then the reality of the field it may be different. So you may also need to understand if that original idea that program implementers had was actually implemented according to plan, especially in projects that are ultimately not implemented by an NGO or something, but it really involves, for instance, public sector officers who need to implement a program that they didn't design, right? So you really need to understand what are the incentives from those in the ground implementing the program to see if the program is really implemented as it was originally planned. Next slides. So the I'm gonna show today a little bit is more some of the things that are very important when you are designing an evaluation of a program like this is the evaluation should follow the design. We should, as researchers, we shouldn't be basically tweaking the programs just for the sake of us having a cleaner and nicer evaluation and being able to publish the beautiful results in journals. This is not how we learn. What we really need to do is to understand what intervention is really being implemented, and based on that, you set your evaluation design. So that's a key thing. Another thing that is important, and it was being discussed in the panel that we did back on Tuesday, is in many of these evaluations, sometimes it's very important to follow the same beneficiaries over time. So a longitudinal design. So basically, you collect data from potential beneficiaries at baseline. Then the program enters and starts working with the beneficiaries, and then you collect data at the end and see basically what is going on for those who participated, as well as what happens with the potential comparison or control group, so that you're also able to assess the impacts of the program. Being able to, for example, in many of these evaluations to define really well what are the outcomes of interest for your evaluation. What are the type of things that you want to understand if the program is able to change, right? So things related to intermediate and long-term outcomes, things related, for example, levels of knowledge. Is the program being able to improve the levels of knowledge in terms of what constitutes better nutrition or a healthy diet, or whether households are being able to adopt those practices and adopt the consumption of some specific food groups or specific foods, or things related to the drivers. What are the levels of women empowerment? We saw it in the presentation of Jan Lowe, how important it was for their case to also understand what is happening in terms of women bargaining. And things related to outcomes, for example, related to diet diversity. So what I'm going to show today, for example, has some outcomes that is related to some standard outcomes on diet diversity that are being used in many different types of evaluations. So in particular, I'm talking about the minimum diet diversity for the women and for the children, right? So we will see a little bit of that information in terms of how diverse those diets are, because that's one of the ultimate goals of this particular project. But also we want to see levels in terms of resilience. Resilience is a very hard concept to define, but in terms of nutrition, you could think of ways in which you can see the household food security index, right, as a way to understand how prepared households are for different shocks in terms of their food security levels. And in the data that I'm going to show today, we are going to be we are evaluating a program that is very similar in 6 countries. So the 6 countries were in the map that is before. So we have, of course, Kenya, but we also have Ethiopia, Uganda, Mozambique, Benin, and Nigeria. In each one of those countries, we are collecting data for 1,200 observations. You need enough sample sizes to be able to detect changes in outcomes. If your sample sizes are too small, you may not be able to have enough statistical power to be able to say if the program is really changing the outcomes that the program is supposed to be changing. Okay, so now let's go to, actually go to the description of program, the next one. Just actually go back to the previous one. The data that I'm going to be presenting today in the 6 countries, it is for very specific areas in these countries. I think what is important for you to understand is, in particular in Kenya, the data was collected in 3 specific counties. So we have Nakuru, we have Nyandarua, and Nairobi. This is important because the first 2 are rural, agricultural-based areas, but the other, Nairobi, is not really Nairobi, but it's in the outskirts of Nairobi, is already as a peri-urban area. And that difference is so important because you are going to see that behind the results that I'm going to show for the entire sample in Kenya, sometimes we are missing the key differences between what is happening in these peri-urban samples versus the more agricultural-based data. So this is something that I want you to keep in mind once I start showing some of the results. Okay. So go to the next slide, and then the next. So what I'm going to be presenting now, so you get a sense of basically what are the samples we are working on. So the first disclaimer that I want to say is the data that we are presenting today is, of course, not a representative sample of each one of these countries. So it is specific for this project. But once you see the data, and I have done a lot different work in agricultural evaluations here, for example, in Kenya and some of these countries, it is remarkable how many of these things you keep seeing in many of these agricultural areas. So I guess what I'm trying to say is that even though the data that I'm presenting is very specific to this program and this target, you are not going to be surprised by many of the things that are happening here, which can be happening in many of the other counties that we are not being included in the sample. So, but you will tell me how you feel about this. So let me tell you a little bit about the composition of, I was telling you before that in each country, we collected data for 1,200 observations, and in particular, 1,200 women. And if that woman happens to have a child in the ages of 0 to 23 months, we were also interviewing and understanding the characteristics of that child. So who are the women in our sample? So just because of the composition of how the sample is, the average age of the women in the sample is around from 30 to 36 years old. So I'm presenting the data, by the way, for all the 6 countries that are included in the evaluation. So I'm going to, in the interest of time, I'm not going to be able to discuss every single characteristic, but I'm going to try to highlight the things that I think are more important to understand. So the first thing is that because of the target population that we have, the women that we have here are not necessarily super young, but they are kind of in the middle of the, if you basically restrict the sample to be women of reproductive age, starting, I don't know, at age 15 or 18, all the way to when reproductive age ends, then you basically are going to have a distribution, and that's why you may end up with women who on average are of this age. The other thing that is that was very interesting to see in all of the countries is that it is clearly that because of the nature of where the sample is being collected, there are relatively low levels of educational attainment. This is important because, again, many of these projects are on nutrition. They can be they can be hard. I mean, I always think even for people who have a lot of knowledge on nutrition, like you guys, it is sometimes very hard to understand some of the concepts. I keep thinking, even for someone like me, when they come and say, you are missing key vitamins in your diet, right? And like really understanding what it means, the quantities, everything sounds like science fiction in a way sometimes when we are going into all these little details, medical concepts that we just don't basically use on a daily basis everywhere. Now imagine trying to transfer knowledge to women with who are basically in agricultural settings with, again, relatively low levels of educational attainment. So many of these programs need to understand that sometimes when you are assessing knowledge, you are not necessarily assessing the medical knowledge. It's more like the practical knowledge, right? So some of the things that what are the positive consequences of, for example, having a diverse diet in terms of your health, your growth? But I see a lot of evaluations where sometimes in the knowledge questions to assess the program, they ask uh, like the medical mechanisms, like what happens if you consume vitamin A? What is the type of specific aspects in the body that are being changed or something? So it is not should be the type of things that we should be assessing in terms of knowledge. Next slide. One thing that I find very interesting in many of these countries, sometimes with the exception of Ethiopia, but for the other ones, I see a lot of similarities. In many, not only in the characteristics, but in many of the outcomes that I'm going to be describing in a moment. Some of the things that I want to highlight here is that we still see in many of these target countries that even though there's been a considerable reduction in the number of members in the household, these are still relatively large household sizes. So in Kenya is about 5 people per household on average. That basically means you have probably the mother, the spouse, and 3 kids. You will see that in the distribution, it's not that they have, for example, a lot of senior people living within the household. That's not really what is going on. It's basically that they are still transitioning in the demographic transition. They are still having probably many more kids than what is usually you find in developed countries, where now they are actually not having enough children. Next slide. In many of these countries, we were also trying to understand, if you are going to implement a program, you really need to know what those communities are already receiving. What are they engaged with? What are the type of nutrition services they are able to receive, and what type of program they are able to access? So in particular, sorry, I'm trying to see better here because it's too small for me. Let me just do something. It's too small. I'm not able to read the small letters without the glasses. Okay, sorry. So in particular, I'm gonna concentrate on in terms of basically what happens with the case of Kenya. Many of these populations, yes, they receive some services. So for example, some 11% you see there of these households are able to receive any agricultural, health, or income programs. 11% is just a little bit. So these are communities that are not receiving lots of potential services or programs already. There are some who are receiving, there are 10% who are receiving a cash transfer. But again, it's not the vast majority. It's just a specific part of the population. Now, if you see the lower panel, when we are asking in terms of the availability of some of the services that they have, only 13% say that they have availability of nutrition services, right? Or whether they received nutrition services in the last 12 months, only 9%. So these are communities, because this is the baseline, right? Before the program starts, these are communities that were targeted because they really need this type of support. So this is good. This is good. That basically means that is a good targeting. So there is going to be room for making improvement in those areas. Next, next slide, and actually the next one. So when we were asking also in terms of knowledge, as I was saying before, some of the things that you are always interested, if you are really trying to understand the diet diversity and the quality of the diets, it's a usual question to ask, what are the important or the food groups that should be included in a diet, right? And you see that we have there vegetables, fruits, legumes, whole grains, nuts. Ideally, you would like to see people to be able to say everything. A good diet is something where you are consuming from all the different food groups. And in here, you can see already that even though for things like vegetables, there is very large consensus of the importance of having vegetables, there are things like the consumption of legumes or whole grains or other things where people don't necessarily have that knowledge yet about the importance of being able to consume these type of things, right? So this is just an example of the type of things that you are trying to check in terms of knowledge. Next slide. Now, I'm going to start talking a little bit about some outcomes, because the intervention, many of these interventions are going to come. And ultimately, what I was saying before is they want to change your diet diversity. They want to change the things that you eat, right? But because many of these households are agricultural households, one key thing to understand is, what are you producing? Because of course you are going to be able to get many of the things that you produce in the market, but it's also interesting to know what are you producing, to see if you have access to those foods from your own consumption. And one of the things that I found very interesting when looking at the data is that we, as in many agricultural surveys, we also ask, if do you produce any crops? Yes, I do. Tell me everything that you are producing and in what areas, right? And what was very interesting to see in this case is that the average number of crops produced in all of these countries was relatively low. So if you see, for example, in Kenya, it was 2.6 crops on average. I will go in detail in a moment. And everything is like a little bit around 3. So, and once you see what those 3 are, is usually a cereal, a root, and maybe a legume. So what I'm talking about here is in many of these countries, they are very, I mean, we have 6 different countries, and somehow you keep seeing very similar patterns. A cereal, in this case, for example, the next slide, in Kenya, is we are talking about people who are, this is not surprising for anybody here, of course, a really large part of the households producing maize, a really large part of the households consuming some Irish potatoes, and then beans. But if you keep going down, I'm sorry, next slide. If you keep going down on the list of things, you see very little productions of other fruits and vegetables, right? Maybe they are doing it a little bit, but they don't produce it, or they think it is not important enough to be able to report it when they are asked what are the type of things that you produce, which is still also sending you kind of a signal in terms of how they see their own agricultural production, not necessarily with the objective of eating better, but maybe only for selling things in the market. So this was remarkable because, again, if you see this type of picture in all of the 6 countries, it's going to be remarkably similar. All of the households producing very few type of crops, dedicating a lot of land for cereals. We understand why, of course, but that is at the expense of not necessarily being able to produce many of the other vegetables and fruits that it would constitute a good diet. Next slide. So, no, previous one. Then previous one, please. So one of the things I was mentioning before is that what we really want to understand as an outcome is diet diversity. So we want to see, for example, there is this outcome that is called, maybe you guys are familiar with this, the minimum diet diversity. So the minimum diet diversity is, there are 10 food groups. So you have the cereals, you have the vegetables, you have the fruits, you have all the different 10 groups. If you
have 5 minutes to try English.
Really? You can allow for more time, additional time, so we still have 20 minutes.
20 minutes?
Yes.
Okay. Thank you.
Chair, I beg your indulgence for that. Okay.
Okay.
Thank you. So I'll try to be more synthesize a little bit more. So one of the things that I was mentioning before is that there is this outcomes that is called the minimum diet diversity. So you have 10 food groups, and the way that that outcome works is if you consume 5 or more of those 10, it is considered that you have a minimum diet diversity. Now, so that's the one that is called MDDW, but the one that is below that is called all 5, if you are consuming 5 of the key on a given day, 5 of the key food groups. So if you are consuming a legume, a vegetable, a fruit, a protein, right? You have like all these different ones, and that also may be a good outcome to understand how people are basically eating on a regular basis. What you can see here is that in all of the countries, the results are super similar. Again, this is surprising to some extent, or maybe not. In terms of minimum diet diversity in Kenya, we see 52% of people in the sample saying that they consumed more of these 5 groups. So that basically means that there are 48% in the rest of the sample who are not, right? But even more striking, when you ask about the 5 main food groups, the one that is called all 5, there is very little, only in Kenya, only 21% of the people in the sample saying that in the day before the survey, they actually consumed all of the 5 key food groups that people are supposed to consume. This is very important. There is a lot of room for improving. Maybe there is a little bit of improving in knowledge from the households, but that's not only it. Knowledge is just a little part of basically what you need to do. There are many other things that the programs and the public sector can do in order to help improve many of these type of indicators in some of these countries. Can you go to the next slide and then the next? Something I really want to show you here is this difference. So as I was saying before, in Kenya, our sample was collected from 2 agricultural-based counties, so Nakuru and Nyandarua. Am I pronouncing well the name of the? And then we also have some part of the sample that is a little bit more peri-urban, the one that is Nairobi. Something that I found, and I would like to hear some thoughts from you at the end, is that I was expecting some differences, of course, from Nairobi versus the other ones, but actually I was expecting differences in the way that I thought the Nairobi people in the sample were going to have much better levels of food diversity than the agricultural ones. Maybe that was ignorance from my side. It was quite the opposite. So basically, when you see, for instance, the MDD, which is the minimum diet diversity, so that's indicator 1.2. So in Nakuru, we have almost 58% of the sample saying, yes, I consumed more of the 5 groups. 54% of Nyandarua saying, yes, I consumed 5 or more of the food groups. But it was only 45% in the Nairobi sample. And when you see things related for the all 5, so remember these are all the key 5 food groups, it was 24% for Nakuru, almost 23% for Nyandarua, but it was also 18% in Nairobi. So it is interesting because I think that's where the qualitative data is going to be useful, because then you are going to try to understand maybe the levels of income of of people in the Nairobi County are maybe they are a little bit higher than the ones in the agricultural households, and yet the food prices or the access to be able to find other types of foods in the area is having a negative effect on those who are in the peri-urban areas. Next slide. So not surprising when we see these results also, and we try to understand the levels of food insecurity in many of these countries. Again, very similar levels of food insecurity. If you see the bottom rows in the presentation, you would see that, for example, in Kenya, the moderately food insecure is 39% of the sample, and the severely food insecure is 41% of the sample. This one is using that index that was created by USA, that is the Household Food Insecurity Access Scale. So it's a way of basically understanding through a series of questions how insecure in terms of food access your household is. And so what you see is that between the two rows, there is almost 80% of the sample being either food insecure or severely food insecure. And this is common in perhaps with the exception of Ethiopia. All of the other countries are very similar in the results. And again, next slide, if you see these results by county in Kenya, again, you will see that only 4% of the households in Nakuru are food secure relative to 19 in the other counties. But and there are still some important differences between the peri-urban and the agricultural households. So something to think about when you are doing these quantitative evaluations and you basically pull all the sample and you just present one number. Sometimes you are forgetting that behind that average, there are very different subgroups that you really need to analyze. And this is an important part of kind of a learning lesson from this exercise. Next slide. Actually, I wanna, if you go, I'm not gonna go just in the interest of time in the things related to women empowerment so much. I guess what I want to say is that in many of these evaluations, they tend to use some outcomes in terms of how much saying women have in the decision-making process in a household. And then the indices, because of the way they are constructed, they can give you kind of a not very accurate picture sometimes of what is behind. And some of the things that we learned, for instance, if you go to slide 27, next one, that one, is that when you ask women in the household whether, for example, they can make personal decisions around minor household expenditures, such as daily food expenditures, 58% of the sample say yes, we are able to make that decision, right, to some extent, which basically means that there is still more than 40% of the sample of women who are not being able to make decisions in terms of like the things that they consume and they buy for food consumption, even though they are ultimately responsible in many of these households for the nutritional aspect, and they are the ones who are receiving the trainings. So that's why the women empowerment part is so important, because you are providing them with trainings in terms of the importance of nutrition. You are inviting them to these clubs so that they work together. But ultimately, if a big part of this of these populations are not able to make the ultimate decisions to improve the things that are eaten in the household, then you are going to see very little impacts from some of these programs. So what I go to the next one. So I'm gonna, what I wanted to show today here was basically the way that we usually operate when we are doing an evaluation, and the type of things that we are trying to understand, how important it is to have a rigorous design that is not only very quantitatively and methodologically strong, but also being able to complement it with qualitative data to be able to define really well what are the type of outcomes that you're going to be following over time. What are the considerations that are not only happening at the household level, but also at the national level with the regulations, with the private sector providers, and so on. So those are some of the things that I wanted to mention today. I thought I was going to have a little bit more time, but and that's why I was going to link this evaluation with the one that we are doing in Tanzania, but I don't think I'm going to have a lot of time just basically to go over that. If anything, I just basically want to tell a quick story without the slides. In Tanzania, we have
How many time do you want? How many minutes?
Chair, the time ends at 10:25. So plus questions, so you can add. Yeah.
Yes. Let him continue.
Okay, thank you. So go to the next one. So I'm gonna briefly discuss another project that we are doing in the Lake region, in the Lake Victoria region in Tanzania. That is a program that is trying to incentivize communities to adopt orange-fleshed sweet potato. This is an area in the Lake region where many of these communities have been producing for many years the non-orange varieties. So the sweet potatoes that are white, they are yellow, they are purple, which is good, but they were missing out to some extent to having the opportunity of including as part of their diet the orange variety, which is a superfood. So relative to the other ones, the one that has much higher levels of not only vitamin A, but many other different types of minerals and nutrients is the one that is orange in color. And as you guys know, and from the previous presentation that it was given by Jan Lowe, vitamin A, the lack of vitamin A is not only important for night blindness, it's also for households that do not eat very well, right, and have very low levels of food diversity, especially for children. It could be a matter of life and death, in the sense that a child that is not very well, it doesn't have a good levels of diet diversity. Once that child is sick and, for example, is experiencing diarrhea, the likelihood of dying from once you are vitamin A deficiency is much larger than if you are not. So being able to have access to these other type of crops is essential for many of these communities, especially the ones that have very high levels of vitamin A. So please go to the relevance one. So there are in Tanzania, in many parts of Tanzania, but in particular in our areas, there are high levels of vitamin A deficiency. So as I was saying, in many of these, very not surprising based on what I was describing from the previous evaluation. Once you go to this area and you see what people are consuming, you're gonna see a lot of maize, a lot of rice in their diets, and very low levels of consumption of other things, including, of course, things that are rich in vitamin A. Next slide. So the key thing is that when you have a situation like this, you say, oh, there is a community that is already producing sweet potatoes. We have another sweet potato that is much better. They already know, they know the technology, they know how to produce the sweet potatoes. Now what we just need to tell them is, instead of producing the white and yellow, why don't you produce the orange one? It has these many other positive characteristics that are going to improve your health. You would be surprised how difficult it is to change behavior, even in that simple situation. We were saying on Tuesday that changing behavior is hard, is difficult, and it's not only about knowledge. It's not only about basically telling people, trust me, you are going to be much better. This is not how it works. It's not only you need to come up, you need to be able to understand if people are going to be able to have access to the planting material, that is good, that is productive, right? You also need to change the minds, not only of the women, for example, which is sometimes in terms of nutrition is very similar, is very easy. You need to engage the males in the equation, because if they keep thinking that something like orange-fleshed sweet potato is a female crop, You do what you want there. This is not my issue. What happens in the kitchen garden and in the kitchen is not my problem. And this orange flesh sweet potato is baby food, right? Once you do that, they many other people in the household are gonna also be missing out on the opportunity of have access to improving their diets as well. So not only there are big barriers to adoption, but even more striking, there are a lot of constraints for sustained adoption over time. In many of the projects that we evaluate and we see, you start with the project, you provide the vines in this case, you see people are really happy receiving the OFSP vines. In the first agricultural cycle, you see a big jump in OFSP production. You see very high levels of vitamin A levels, the high levels of production. So you basically think, oh, the program is successful. If you keep following the same households over time for multiple agricultural cycles, you will see that after 3-4 years, if you are not providing the households with the vines, they are going to go back to the non-orange varieties. And it's not because they don't like it. It's just because they are not finding the planting material that is available. The planting material that they were able to preserve from the beginning is already not very productive, is being subject to viruses and other types of pests. So you really need to be able to change your planting material. But if the planting material is not prevalent in the region, then it's not going to be that easy. So there needs to be a coordinated effort by the government, the local authorities, for example, in this part of Tanzania, to make sure that there is continuous production and supply of the vines that people are going to access. But with a key aspect here, which is because there are not enough vines of OFSP available. And so sometimes they train champion farmers to basically produce the vines with the idea that is going to be the source of the future vine so that the OFSP production is more sustained over time. But guess what happens? Maybe you can only train 50 farmers in a large area. Those farmers who are trained to produce the OFSP vines to later disseminate and sell in the area, they know that crops like this are fancy and that international organizations, they really like it, and that they are able to pay 30 times, I'm going to repeat that, 30 times more than the cost of the non-orange varieties. So if getting a vine for white sweet potato costs, I don't know, $1, the same vine for OFSP is 30. Farmers are not going to buy that. They are not. This adoption is going to happen. Even if there are vines in the communities, the fact that there are not enough producers in the area basically means that people are not going to be sustaining the production. So we really need to find ways. And this, when I say we, it's everybody, the local government, the communities, the international organizations, to really think about long-term adoption, because many of these projects, and including the evaluations, when they are not long-term, we only get the happy picture, the first 2 years, but everything is nice and easy. When it works perfectly, when you really get this idea of this is what we really needed to do, we needed to improve the levels of adoption of this superfood. We are seeing high levels of adoption. Our job is done. Thank you very much. And then if they were able to go back in 4 years and see what happened, they are going to realize, what happened to my project? Everything is gone. And I think part of that, and I know that there is limited resources these days for implementation, but also for research. Long-term research is actually very costly, and more is much more difficult to find funding for longer-term projects. But basically, we are missing a big part of the equation in this case. So I think now I'm going to skip many different slides here. I want to go to slide slide 45. I exactly that one. Yes, exactly. And here's what I wanted to highlight in terms of its adoption. So in Tanzania, we started a project in 2018, and we have been following many of those households for many years. So if you see, for example, in panel A, we have the results after 12 months before the project started. In panel B, it is 30 months, and then in panel C, 48 months. So 4 years after the program started. The program, basically what the program did was they provided initially the OFSP vines to the people. They also gave them a little bit of fertilizer. They also gave them trainings, so both nutrition trainings as well as cooking trainings, because as you guys know, OFSP is fantastic for basically being able to produce many different types of things, chapatis, mandasis. You can also have beverages with the leaves. So it is a very versatile crop. And then that's why the nutrition trainings were also very important. So what I want to show you here is, if you see panel A, and where you see OFSP equals 1, that basically is a question that says, did you produce any OFSP, right, in your household, right? So if you see the 38% is in 12 months after we started the project, there was 38% of people in the control group saying, we are producing a little bit of OFSP. So it was part of the control group, but somehow they were able to get interested in OFSP production. Then for those who were receiving the vines and the trainings, we have 26 percentage points more production. So it was, if you sum 26% plus 38%, it would be the amount of the proportion of households that were now producing OFSP 12 months after that. 30 months after that, you see 39 percentage points increase. So it is increasing. So almost after 2 years and a half, you see a lot of households still producing the OFSP. And then you go to 48 months, and then it starts decreasing again to 25%. So this is the picture that I was saying. And I'm sure that we are not collecting this data anymore, but I'm sure that if we go now, just because of the information that I keep tracking qualitatively the region, and I ask my friends in the area what is happening, and they say there is no planting material. I am sure that if we go now, these 25% additional points are now probably close to 10. So basically what you see is a little bit of adoption at the beginning, very high levels of adoption 2 years after the fact, and then somehow people start disadopting, and then it disappears. And all the effort somehow is gone unless we are able to do something. So, yes. So go to the slide 49. So we were checking different types of outcomes here. We were checking different outcomes in terms of diet diversity, consumption of OFSP and other things, including other vitamin A related aspects, because the training is not, the nutrition trainings are not only about OFSP, but it's also what constitutes a good diet. So we also saw improvements in the diets of the children, for instance, but not only coming from OFSP, also coming from other type of things that they were consuming. So the project was really doing a lot of good in terms of not only adoption of OFSP, but also adoption of other type of things that are constitute a good diet. But one thing that is sometimes is hard to understand is sometimes the sample sizes for doing exercises, like understanding if a program is affecting the livelihood of not dying, right, is hard. You really need really large sample sizes. So what I'm going to show here is suggestive, but one of the things that we were finding is when we since we were able to follow these households for almost 4 years, we were able to ask them, in the last 4 years, have you had any deaths in your household? How many? What ages? And some of the things that we see is that those who participated in the program have, not a lot, but slightly fewer deaths in the household. Like what you see there's is like 2 percentage points, a 2 percentage point reduction in the likelihood of dying for children in the household. It's not a lot, but again, it's hard to identify because death is something that is not very common. So it is hard to evaluate things when only a couple of households are going through this event. But there is some suggestive evidence, and it goes in hand with what I was explaining at the beginning, which is OFSP adoption and a good diet is not only about some of the key outcomes that you think. Is not only vitamin A, is not only about night blindness. It could be an issue of life and death. Yeah. So this is basically what I wanted to present. I'm finishing now. I guess the final points that I want to make is research. All of us here is key. We need to be doing research that is informative, that is not for the sake of doing research, that is going to inform policy. We really need to do very good research. The more rigorous it is, the better evidence we have, we are going to be able to have and convince more people about the changes that we need to make. So as researchers, basically, our pledge is just to do as good of a work as we can do, and keep trying to find the ways to conduct this research, even though we know that sometimes conducting research, especially the long-term research that I'm advocating for, is hard to do with all the funding restrictions that are happening in general and these days even more. So thank you very much for the time, and look forward to the questions.
Thank you very much. We don't have time for question, Chair, and we are going to collect all the questions, and then Johan can answer them anytime. So we have consumed all the time.
I apologize for that.
It is so, Chair, back to you. We are not asking questions, but we are receiving questions through our email. Then unless, Prof, you want to just make a comment as the chair, but not more than 1 minute.
Okay, session chair, I beg for your indulgence. This was a very beautiful presentation for us. We would have wanted to ask more questions. But then, since we can't be able to ask, I just wanted to... Yes? Yeah, the data is so big, and I think we can still explore other areas like variety score for testing of resilience and elasticity of feeding habits. Thank you very much.
Yes,
That's a comment.
The question and answer. I've sent my question, I think.
Chair, we can give you a chance to, because this study was done in Tanzania, so you need to make your comment. I think.
Yes, I wanted to ask one question, just a short one. The program went at first, but then people stopped growing the oil sweet potato. What was the main reason for that? What would be the intervention to fix this program in future?
So there are many different constraints. A key one is the one that I was mentioning in terms of access to the planting material, to the OFSP over time. With OFSP in particular, you can plant it 4 cycles. If you are given a vine and you plant it, OFSP is a beautiful crop because it works. The way that you produce it is vegetatively. So basically, you have the vines, and you plant the little vine, but you can get vines that are really long. If you cut those vines, and you plant it, you are gonna get more vines, and you're gonna get more potatoes. So unless other things like cereals, where once you have the seed, this is what you have. Here, it is really easy to multiply it, and share it. But after 4 cycles, you have to change it because otherwise it is exposed to viruses and pests. So after 4 years, if they go back and try to find the OFSP, not only before they were not able to find it, now they are able to find it at a price that they are not willing to pay. So this is a key barrier, right? Because I think the knowledge and the interest is there. So the knowledge and the interest is already planted in the region, but the accessibility to some of these things is what really constitutes a high barrier.
Thank, Chair. We will have a break. Sorry, we changed your sequence of events, so we are making you to appear like you're not a good chair. But I still want to assure you that you are a good chair. We are going for photo session now, and then after that we start at 11. Okay. After tea. Thank you. So the photo session will take place outside there with the keynote, and yes, we are all invited. Thank you. Chair, you are also invited for the photo session. Yeah.